Welcome back to the Talking Ketamine podcast. This is episode 47, The Patient's Voice.
We talk a lot about receptors and protocols on this show, but today we're going to talk about the most important data point of all. What it actually feels like to be the person in the chair.
That really is the crucial shift. For clinicians, success is often this quantifiable thing, a metric on a checklist, right? Like a score on a symptom scale.
Exactly. But for the person living with treatment-resistant depression, success is, well, it's how they live. It's their ability to connect with people again, that sudden return of motivation.
Or just clarity. So our conversation today is really a pivot away from those efficacy metrics and toward the subjective human experience.
It is. And to guide us, we're looking at a comprehensive synthesis of qualitative studies by Walasek and colleagues. This review gathers the collective voice of many patients to understand what influences their engagement and adherence to the treatment.
That sounds absolutely essential. We need to talk about the person, not just the drug. So, our mission here is to trace the experience as patients define it. We'll start with their mindset beforehand, move through the acute state, and then the whole emotional journey after. So let's start at the beginning. Before the first dose is even given, what's the emotional state they're in? We know ketamine is rarely a first-line therapy.
You have to understand the context here as repeated failure. Patients who get to this point have, often spent years in severe depressive episodes, trying one thing after another.
And nothing has worked.
Nothing. So the profound feeling they describe is just desperation. They consistently say they've run out of options and were willing to try almost anything to just get back to basic functioning.
It's positioned as a last resort.
Almost universally, yes. A true last-ditch attempt.
When someone is that desperate, how do they even hold on to any hope? It must be exhausting.
Well, that brings up the key conflict. Ambivalence. The desperation is there, but it coexists with this very cautious, anticipatory hope.
A little flicker.
A tiny flicker. But because they've been disappointed so many times before, that memory generates this persistent hopelessness. They're hoping it works, but deep down they're terrified it's just another failure.
So now we move into the actual session. The dose is administered. What does it actually feel like for them?
The main thing is a really rapid, intense departure from ordinary consciousness. Patients talk about complex perceptual distortions. It's more than just seeing colorful spirals.
Deeper than that.
Oh, much deeper. It's a profound change in their perception of their own body, of space, of time. You hear things like, my hands felt backwards, or I was floating in an empty void. It's very dreamlike.
That sounds fundamentally disruptive. Is the feeling generally a positive one, like euphoric?
It's highly variable. Many do report euphoria, pronounced high, but the emotional tone can just shift on a dime. One moment it's calm and light, the next it can be intense anxiety or panic.
A roller coaster they talk about.
That's the word they use, yes.
Yeah.
A rapid roller coaster.
So if it can be that frightening, how do you make sure the session is therapeutic and not just traumatic?
But that is where context becomes everything. The research is so clear on this. Whether the effects are distressing or beneficial depends heavily on the set and setting.
Their mindset and the physical environment?
Exactly. A quiet, professional, supportive environment modulates the whole experience. The staff support is what can turn a potential panic spiral into a manageable breakthrough.
Okay, so once the acute effects wear off, there's this window, right? The post-acute afterglow.
Yes, and the metaphor patients use for this is incredibly powerful. They call it lifting the blanket.
I like that. It's not about being instantly happy.
No, not at all. It signifies a lighter, more neutral mood. That emotional weight that kept them stuck is just lifted. Worries that were paralyzing feel less charged, more like concrete tasks you can actually solve.
And that must feel like a huge relief.
It is. Patients report more energy, less rumination, and really critically improved social connectedness. Relationships feel easier. And this typically lasts from several days up to maybe 2 or 3 weeks.
But for many, it is temporary. And this leads to that really critical hurdle, the symptoms coming back.
And this is the emotional crash. It's often accompanied by a real sense of grief. When the mood and suicidality creep back, it can provoke intense frustration and renewed hopelessness. It can feel like a deep betrayal.
Worse than before, even.
For some, yes. They describe feeling more hopeless than before they started because now another therapy seems to have failed them. It's a vital risk point that needs robust follow-up.
That leads directly into this measurement mismatch you mentioned. If the patient is feeling that grief, but the doctors are focused elsewhere, how do you bridge that gap?
Well, traditionally, clinicians use something like the clinician-administered dissociative state scale, the K does. They're treating dissociation as this measurable, mechanistic thing,
The active ingredient, so to speak.
the supposed active ingredient. But the problem is, post hoc analyses consistently show no robust association between high CAD scores, so the intensity of dissociation, and the actual antidepressant effects.
So someone could have a very mild experience and still get a huge benefit.
A huge, lasting benefit, yes.
Yeah.
They're missing the full picture because patients define the benefit in these relational, experiential terms that fall outside that narrow definition. They talk about shifts in perspective, emotional release, moments of insight.
So it's not the dissociation itself, but what the patient does with the mental space it creates.
That's a great way to put it. So we have to move beyond just measuring dissociation as a side effect. We need to integrate other measures like the mystical experience questionnaire and, crucially, patient-reported outcomes.
Like asking them if they're satisfied.
Exactly. Something like the TSQM-9 captures overall satisfaction and quality of life, and that satisfaction score directly influences their motivation to continue.
But even if the experience is positive, there are these huge real-world obstacles. Let's talk about why people stop, beyond side effects like nausea.
The first and biggest is cost. Most clinics are fee-for-service, with very little insurance reimbursement. The out-of-pocket fees are prohibitive for many.
That's a terrible feedback loop. You find something that works, but you can't afford to keep doing it.
It immediately feeds back into that hopelessness, and the logistical burden just compounds it. People travel hundreds of miles, they need to take time off work, find someone to drive them. The whole process is expensive and draining.
And then on top of all that, you have the cultural stigma.
Right. Patients are so aware of the horse tranquilizer or pretty drug labels, it creates this fear of judgment from family, from employers, so they keep it a secret.
Which undermines the support they need.
Completely. And what they're asking for is clear, accessible education that differentiates medical treatment from illicit use. They want it normalized as an evidence-based option.
So after all this, it seems like the environment, the human element, is just as important as the pharmacology.
It's integral, not secondary. Patients frame the therapeutic relationship, feeling safe, looked after, as a core benefit. Some value it so highly they say the staff support is almost 50% of the therapeutic outcome.
50%, that's an incredible statistic. It's not just a comfort, it's part of the mechanism.
Exactly. Supportive staff help patients integrate the difficult emotions that come up. They transform potential trauma into manageable, meaningful change. This can't be just an isolated procedure.
It has to be embedded in ongoing relational care.
Especially for when those benefits start to wane, that human relationship can be the difference between a manageable setback and a catastrophic relapse into hopelessness.
So we've traced this whole journey. It's clear that preparation, managing expectations, and relational support are the most impactful variables.
And the challenge this presents is that clinical implementation has to align with what patients define as recovery. We have to integrate those experiential measures and satisfaction scores. The goal should be designing services that are as humane and supportive as the rapid relief the drug can offer.
I think the final thought here is, if a patient sees the clinician's empathy as half the outcome, what does that say about healthcare systems that prioritize fast throughput over deep relational care?
It's a question we should all be thinking about. Thank you for joining us for this exploration of the patient's voice.